So Medea is a medical education academy, and we are a global medical education provider, and we are dedicated to develop and implement medical education around the world for healthcare professionals to increase the knowledge and to increase your ability to help patients during treatment, any field in medical sciences. I'm not alone in Medea, and I have many helpers and advisors, and we cover several therapeutic areas. So besides reproductive medicine, which we'll be enjoying today, we also provide education in cardiology, endocrinology, neurology, and rare diseases. And here you can see the advisory board of experts for reproductive medicine. So as you can see, quite renowned people from several countries in several areas of reproductive medicine who help us to organize and the scientific contents of this kind of meetings. And this will be the experts in endocrinology, and these are the experts in cardiology, experts in neurology, and experts in rare diseases. So I hope you will enjoy today's meeting, and you will also be not only passive but active during the questions and answer session and during the polling questions. And now it's my pleasure to introduce to you my co-chair and the person who was responsible for this initiative and also was very much active putting together the topics for today, Valerie Paddy from Scotland, working at Aberdeen Centre of Reproductive Medicine, University of Aberdeen. Valerie has been involved in fertility nursing since 1993 and chaired the Royal College of Nursing and Midwifery and Fertility Nurses Forum from 2008 to 2011. She currently holds the position of nurse consultant and fertility preservation, and she's member of the European Society of the Human Reproduction and Embryology, ESHRE for nurses and midwives, at the certification committee there, and editorial board of Human Fertility. She is also, in addition, a peer reviewer for several fertility and oncology-related journals. So, Valerie, it's a pleasure for us to have you with us today. And I give you now the stage to introduce our meeting today. And by that, I will step now a little bit back.
Thank you, Robert. So as Robert mentioned, welcome to what is the actual first Medical Education Academy webinar for nurses and midwives, although I am aware that we may have some trainee embryologists and counsellors joining us today. So when I was asked to put together a programme that would be of interest to fertility nurses and midwives, I thought of the preparation of our patients, both male and female, and the emotional support and advice we provide on a daily basis, which is dependent not only on our experience, but knowledge of evidence-based practice with regards to improving implantation potential. So it's gone forward one. So as Robert mentioned, my name is Val Peddy. I'm currently nurse consultant for the Fertility Preservation Service in Aberdeen, and these slides are moving forward without me actually touching a button. So if I could have some IT support, that would be great. So I think we've actually seen the co-chairs in Robert's introduction. So I'd also like just to comment on the global partnership listed in this slide, which are key to contributing to and advancing the knowledge, policy and practice in fertility care. So for nurses and midwives, this webinar has been accredited by the Royal College of Nursing in the UK, the European Accreditation Council and CPD Certification Service. Whilst the official language of the webinar will be in English, there will be simultaneous translation in French, Spanish and German provided for the live sessions, and you can now select your language of choice by clicking on the globe icon at the foot of your screen. So I'm actually delighted to welcome almost 900 delegates from across 61 countries, which actually is quite impressive. So welcome to you all. There was a slight delay in the beginning as we were allowing everyone to access the webinar. The webinar will be split into two sessions, with the first session focusing on pre-treatment considerations and preparation of the patient, and session 2, the support of the patient during and after treatment. You'll also receive an email in the coming days asking you to complete a short survey, and on submission will receive a certificate of attendance with evidence of professional body accreditation for CPD. You'll also notice that the chat facility will allow you to communicate with other participants, which will be anonymous during the webinar. But most importantly, I would encourage you all to submit questions via the Q&A icon again at the foot of your screen, which will be anonymised and selected for discussion by the faculty at the conclusion of each session. And finally, there will be 2 sets of polling questions at the end of each session. Please enter your answer, which will also be anonymised, and results will be collated simultaneously to gauge knowledge and understanding from the presentations. I would say that if you're watching this or listening to this webinar in a group, you might want to switch on handheld devices, because unless you answer as a registrant, you may not actually qualify for certification at the end. So I would ask you to actually answer these questions as an individual participant. So I'll now hand back to Robert to open the first session of this webinar. Thank you.
Yes, thank you very much, Valerie. And the first presentation will be by Chris Barrett. This will be the first lecture that you will watch now. And Chris Barrett will be available later on at the questions and answers session, and also during the pouring questions. And now, Valerie, can you please introduce Chris Barrett to the audience?
I think it's actually my session first, Robert.
Oh, it's your, sorry.
It's my presentation first, yeah.
Yes, yeah, sorry. So it's, I just missed it here. The first presentation will be by Valerie. It's on lifestyle factors and fertility, improving implantation potential with supplements and alternative therapies. So where is the evidence for that? So let's hear from Valerie what she has to say about that.
My grateful thanks to the Medical Education Academy for their kind invitation to present at this webinar for nurses and midwives. And whilst the focus is improving implantation potential, we need to consider lifestyle factors that inhibit or aid implantation and fertility treatment outcome. And this is my declaration in which I have acknowledged receiving an honorarium for this presentation. So the learning outcomes of this session are the awareness of modifiable factors that impact both male and female fertility, the impact of advancing female age, including physiological factors, stress, and the impact this has on mental health and well-being. I'll also cover the harmful effects of the most commonly used recreational substances and supplements, both evidence and non-evidence-based, and the availability of treatment add-ons, all of which impact either directly or indirectly on endometrial receptivity. And finally, I'll explore the role of the internet and patient dependence for information and support. The available evidence suggests that lifestyle factors such as diet, quality of sleep, environment, and other behaviours have profound effects on health and disease, with fertility being no exception. I'm a firm believer that mental and physical health are inextricably linked, and if you don't have one, you don't have the other. Whilst the lifestyle focus tends to be on women, a number of lifestyle factors affect both genders, and these are limited not just to diet, BMI, exercise, and stress, but include environmental and occupational exposures such as smoking, alcohol, substance misuse, and certain medications. According to Gaskins and colleagues from the US, the evidence to suggest a potentially detrimental effect of moderate alcohol and caffeine intake on fertility appears to be lacking. They go on to suggest that the most salient gaps in the current evidence include consideration of both female and male diets and testing the most consistent findings in a randomized controlled trial. There's no doubt that female age is the largest predictor of fertility treatment outcome, and it's well known that female fertility potential begins to decrease after the age of 30 years, primarily as a result of a decrease in ovarian reserve and available oocytes, and as a consequence of a continuous process of oocyte atresia. The age-related decline in fertility is also characterized by a decrease in both oocyte quantity and quality, in addition to changes in the expression of biomarkers of ovarian activity, such as increasing levels of FSH, decreasing levels of anti-Müllerian hormone, and inhibin B. Nevertheless, women want to know their individual chances of success and time to pregnancy, something the Poseidon criteria has actually given us help with, all of which can be determined by the various factors listed in this slide. Medical history also plays an important part in this prediction. Maternal history of premature menopause, previous exposure to certain medications such as chemotherapy and methotrexate, which is commonly used in the treatment of autoimmune conditions, in addition to smoking, are all considered contributory factors in the decline of ovarian reserve. And as we've known for some time, previous smokers are often reliant on an increased dose of FSH for ovarian stimulation. So, given female age is the single most important factor in assessing ovarian reserve, it's also linked to an increased risk of aneuploidy, obstetric risks, and fetal anomaly. Interestingly, low AMH concentration has been associated with an increased risk of embryo aneuploidy in women of advancing age, but not in younger women, suggesting that embryo aneuploidy risk was mainly due to advancing age and related to changes in oocytes and not to ovarian reserve in isolation. Endometrial receptivity might decline with the advanced age due to unknown biochemical or molecular abnormality of the endometrium, and this decline could also be the result of a higher incidence of other pathological conditions in the uterus, such as myomas or polyps. In addition, hypertension and other systemic disorders are more common in older women and could be contributing to the reduced potential for implantation and successful pregnancy outcome. However, donor eggs have provided women of advancing age with an increased chance of success, but obviously not acceptable to all. Researchers in Barcelona found that the chances of women having a baby through IVF was only 1.3% using their own eggs in those aged 40 years and above, but when using donor eggs, increased considerably to 24% in women aged 38 to 39. Obviously, they didn't account for women over the age of 40. Therefore, fertility nurses have an obligation to be honest with women and to raise awareness of age-related fertility decline, and to remember that social egg freezing may not be the answer. Obviously, this is dependent on age at time of storage. The literature further suggesting that on average, women would require between 10 and 15 metaphase 2 stage oocytes to give a reasonable chance of live birth. With regards to physiological factors, stress is a prominent feature across all societies, whether physical, social, or psychological. Living with infertility is stressful, and societal pressures such as friends announcing pregnancy, monthly testing for ovulation, or frustration associated with irregular cycles, repeated treatment failures, disruption to one's life plan, in addition to the financial costs with which fertility treatment is often associated. The hypothalamic pituitary adrenal axis, when activated by stress, exerts an inhibitory effect on the female reproductive system, with cortisol inhibiting GnRH secretion and glucocorticoids inhibiting pituitary LH and ovarian estrogen and progesterone secretion. These effects are responsible for the hypothalamic amenorrhea of stress, which is observed in cases of anxiety and depression, malnutrition, eating disorders, and also in chronic excessive exercise, low BMI having an equally negative effect on fertility as raised BMI. Males who experience more than 2 stressful life events before undergoing fertility treatment were more likely to be classified below the WHO standards for all sperm parameters, with stress and depression thought to reduce testosterone and LH pulsatile action, which disrupts testicular function. A healthy body mass index is important for fertility, and this should be, for women, between 18.5 and 24.9. Given women store almost a third of the required level of estrogen in their fat cells, those with excessively low BMI will also experience menstrual dysfunction as a result of pituitary suppression, excessive exercise and top athletes being a prime example. This group of women are predisposed to reduced bone density and osteoporosis later in life. With regards to men, male obesity has also been linked to reduced semen parameters and has also been suggested that high-fat dietary exposures could affect the epigenetic content of sperm or the endocrine content of seminal fluid and thus impact early fetal development. With regards to physical labour, a study by Stanford University in California suggested that men who were exposed to intense physical labour in the workplace were twice as likely to have a low sperm count. The same study also reported that using certain medications or an increased number of medications lowered sperm concentrations. And finally, men who rely on anabolic steroids for building muscle mass are at an increased risk of inducing negative feedback on the hypothalamic pituitary compound and inhibiting both FSH and LH secretion, leading to either oligo or azoospermia in addition to hypogonadism. So with regards to preparing our patients for their fertility journey, it's really important to remember that they lead busy and successful lives out with fertility treatment, and that we have a duty of care to ensure they are well informed and supported throughout. I've therefore actually taken some patient perspectives from the UK HFEA website. The HFEA is the regulator for all licensed clinics in the UK, with the majority of these statements accessed from the patient testimonials. Fertility nurses and midwives are best placed to advise patients on the importance of self-care and not to focus purely on the physical aspects of IVF. For some, IVF is not simply a physical challenge, but according to this patient, a mental marathon also. So ensure your patients appreciate that everyone is different and they will receive quality care that is individualized to their specific needs. There were many aspects of fertility treatment that patients couldn't control, for example, antral follicle count, number and quality of embryos, and treatment outcome. However, patients can shift focus to what they can control, for example, their mindset, attitudes, and outlets for stress. They can also put practical coping mechanisms in place. There's no denying that fertility treatment is a stressful life event, whether it's managing multiple clinic appointments, juggling work commitments, or telling friends and family that they're going through treatment. Whilst there's no known studies to show that stress impacts on the physical outcome of fertility treatment, patients should be encouraged to be open to emotional support and aware of the counselling options available to them at their clinic. But most importantly, ensure they take time to relax and unwind and do what feels right for them. And if that means fitting appointments into their daily routine that involves going to the gym or socializing with friends, then this should be encouraged. It's also well documented that cigarette smoke contains over 4,000 chemicals and is associated with a number of potential health complications such as cardiovascular disease. But more research is needed to establish a link to infertility. Ogood and colleagues determined that women who smoked had a significantly higher odds ratio of infertility in comparison to non-smokers. The reduction in fertility among female smokers may be due to a decrease in ovarian function and ovarian reserve. Men who smoke tend to have a decrease in sperm count, density, motility, morphology, semen volume, and also fertilizing capacity. One study also determined a link to reduced binding capacity. Alcohol has also been associated with multiple reproductive risks, including fetal alcohol syndrome, but obviously that's linked to excessive alcohol intake, and an increased risk of early pregnancy loss. But how much is too much? According to a study by Lingsgo and colleagues, low to moderate average weekly alcohol intake and the chance of achieving a clinical pregnancy or live birth following treatment was not statistically significant. Yet our recommendation is also always to abstain from alcohol when trying to conceive. Studies of the effects of illegal drugs on human fertility have been scarce due to the ethical considerations, as well as subject to underreporting and bias due to the characteristics of the population being studied, and often, as stated in this paper, attributed to low socioeconomic status or lack of antenatal care. Marijuana, more commonly known as cannabis, is one of the most commonly used drugs around the world and acts both centrally and peripherally to cause abnormal reproductive function in both genders. Therefore, the use of recreational drugs appear to have a negative impact on fertility, although we know that more in-depth research in this area is required to make a clear link between the two. With regards to supplements, clinical evidence on the role of antioxidants in female fertility is also scarce. However, there is good quality evidence for the supplementation of both folic acid and vitamin D. The World Health Organization strongly recommends all women of reproductive age to take 400 milligrams of folic acid pre-conception, in addition to consuming food with folate from a varied diet in order to prevent neural tube defects. A higher dose of 500 milligrams is recommended for certain groups of women, for example, those with previous history of neural tube defect, diabetes, malabsorption, and smokers. However, we must never forget that the richest source of folic acid may in fact be from our diet. Vitamin D, as we know, is a fat-soluble steroid hormone with several physiological endocrine functions in the female reproductive system, and is also known as the sunshine vitamin. Additionally, it is involved in the regulation of ovarian and endometrial cell proliferation, something I actually didn't know before I prepared for this talk. And women are advised to supplement vitamin D during pregnancy to maintain recommended levels of calcium and phosphorus. However, with regards to fertility treatment outcomes, Vitagliano and colleagues suggested serum levels of vitamin D didn't actually influence treatment outcome, raising some concerns about the expected efficacy of these ingredients in commercially available products. Coenzyme Q10, or CQ10 as it's more commonly known, is a free radical scavenger acting as an antioxidant and playing a crucial role in the regulation of metabolism. The limited evidence suggests that it plays a role in the protection of female gametes from oxidative stress, yet only poor quality studies exist which suggest supplementation was associated with a slight improvement in egg quality in both animal and human studies, with a potential role in the prevention of post-ovulatory aging in infertile women, a finding which I would absolutely apply with caution. With regards to DHEA, the minimal evidence available suggests that it improves ovarian function, increases chances of pregnancy by reducing aneuploidy, and lowers miscarriage rates. Nevertheless, some would argue that improvement of egg and embryo quality with DHEA supplementation potentially suggests a new concept in the prevention of ovarian aging, where ovarian environments, but not eggs themselves, age. However, robust quality studies are required to disprove this, as in my opinion, female age will override this benefit every time. The findings of Vitagliano and colleagues also raise serious doubts about the potential effectiveness of most commercially available dietary supplements for improving outcomes of fertility treatment. In the UK, an agreement between the UK regulator, the HFEA, and 10 other professional and patient bodies in 2019 suggested that treatments with no strong evidence of their safety or effectiveness should be offered in research settings only, and patients should not be charged extra to take part in research or clinical trials. The HFEA therefore introduced a traffic light system, attributing red to add-ons with no evidence for their implementation, amber for limited evidence, and green for good quality evidence, all of which should be incorporated into clinical practice. Given the focus of this webinar is improving endometrial receptivity, I've included endometrial receptivity array, ERA, but in healthy patients is rated red by the HFEA because there is absolutely no evidence from randomized controlled trials to show that the procedure improves implantation rates. Another considered add-on is endometrial scratching, which has been given an amber traffic light rating because there is conflicting evidence from RCTs to demonstrate its effectiveness. And finally, immunological tests and treatments for fertility has also been given a red traffic light rating because there is absolutely no evidence for its implementation in healthy patients. So endometrial preparation is one of the most important steps for ensuring embryo transfer success. However, there's no clear evidence that identifies an optimal endometrial preparation protocol for frozen embryo transfer. The preferred approach appears to be HRT preparation, which, in addition to improving outcomes, also allows for clinic planning. However, some women actually fail to respond to this approach and at mid-cycle ultrasound assessment present with reduced endometrial thickness or dominant follicles, suggesting an ovulatory cycle which wouldn't allow for accurate synchrony with the date of transfer, embryo development, and duration of progesterone. In addition, many studies have attributed treatment success to endometrial appearance at the time of transfer and visualization of the triple line on ultrasound. With regards to luteal phase support, Elena Labarta and colleagues from the IVI group in Spain published data on the threshold of serum progesterone on the day of embryo transfer in HRT cycles to improve treatment outcome. And in a subsequent study, they demonstrated an increased implantation rate when adding subcutaneous progesterone to vaginal preparations on the day of transfer, and that's something we have actually found beneficial in Aberdeen. A recent debate published by Jacobs et al. In Fertility and Sterility and entitled "How Thin is Too Thin?" suggests a pragmatic approach with no clear consensus on endometrial thickness or appearance. With regards to egg, sperm and embryo quality, I know that Rachel will cover this in her presentation. There's no doubt that women in particular refer to the internet for information. However, information from different sources can be conflicting. In a study by Jones et al. In 2020, patients were directed to educational material on common fertility topics in text and video format posted on the clinic website and social media accounts. They concluded that patients found online fertility information useful for making treatment decisions and had the potential to improve patient care by empowering patients with the knowledge to make more informed treatment decisions and improve the quality of time spent with the fertility nurse or physician. However, bearing in mind that study actually used very carefully audited and screened information. There's also, as we know, there are some excellent online resources, but there's also a lot of harmful information and inaccurate information out there. And we need to be aware of the Dr. Google effect when patients attend consultations with information or Google research they've obtained online. However, living with infertility can feel isolating, and the internet can actually provide anonymity, emotional support, and normalization for some. Therefore, online infertility networks can play a valuable role in helping people deal with the emotional stress and isolation they feel during and after treatment. However, it also has the potential to reinforce isolation. So it's therefore our responsibility to direct patients to reputable websites and patient decision aids and ensure adequate emotional support before, during, and after fertility treatment, irrespective of outcome. So in conclusion, lifestyle choices do count. Therefore, awareness of modifiable factors that affect fertility is really important. And this includes reducing stress and the intake of substances, which are thought to be harmful to fertility. Advancing female age is the most accurate predictor of the overall chance of success through natural conception or fertility treatment, and to date, evidence has yet to refute this. However, physiological factors require medical intervention, which should be evidence-based. And finally, as fertility nurses and midwives, we have a duty of care to ensure our patients receive accurate and honest information, in addition to appropriate emotional support before, during, and especially after fertility treatment, irrespective of outcome. And these are my references, which will be available to delegates after the event.
Thank you so much, Valerie. It was an excellent introduction to our meeting today, and it's a very important points that you made, especially with the add-ons in treatments, which many of them without enough evidence to support using them. And I'm sure that during the Q&A session, there will be quite a nice and important discussion on that matter. I am sure of that. So now I really invite you to introduce Chris Barrett and for his presentation, the second presentation for today.
Thank you. Thank you very much, Robert. So we'll now shift our focus to predominantly the preparation of the male patient. And as Robert said, I'd like to introduce Professor Chris Barrett, who is head of the Division of Postgraduate Medicine at the Medical School and head of Reproductive Medicine Group at the University of Dundee, as well as a clinical scientist with NHS Tayside. Chris was recently appointed to the editorial board of the WHO for the development of the 6th edition of the Semen Analysis Manual and the global WHO guidelines for semen reference ranges last year. And therefore, who better to present a global approach to addressing the policy, research and social challenges of male reproductive health. Thanks, Chris.
Hello, my name is Professor Barrett from the University of Dundee in Scotland. I'm going to talk to you today about a global approach to try and address male reproductive health and how we can develop a better system for investigating male infertility. I don't believe I have any significant conflicts of interest that would change the way that I provide information to you today. So what are the learning objectives of this talk that I'm going to give? Well, first of all, I want us to try and understand a little bit about male reproductive health and why it has lagged behind female reproductive health. I'm then going to discuss how global collaboration is perhaps the way that we can go forward to try and address this gap and these issues. And I'm then going to try and give 4 examples of where global collaboration will bring us together to try and identify these challenges and make progress. And at the end of that, I'm going to give us what are these global collaborations and how, in fact, can you get involved to try and help us develop male reproductive health. So the first thing I'm going to talk about is where are we now? And the next part is going to be how we move forward in the future. So if we deal with, for example, where we are now. Now, we're incredibly lucky in reproductive medicine because basically we're part of a multi-billion-dollar industry that is incredibly translational in nature. We have many, many societies that are thriving. For example, ESHRA, ASRM, Aspire, and they are just fantastic meeting places where we can sort of discuss future ideas, etc. And some of the science in our field is truly breathtaking and outstanding. So, for example, the in vitro generation of germ cells. Hopefully, in the next 10 years, that's going to be taken to some reality for clinical treatment. And there have been incredible strides in genetics of reproduction so that now we can get some real feel for what could be a diagnostic and prognostic indicators. The other thing that is fantastic in our field is the public interest. Everybody is interested in reproduction. So that's just great, because when you're a scientist trying to sort of translate information to the public, if the public is sort of, we're not very interested, you've got a really uphill task. Whereas in this nature, that's not the case. Everybody's interested in reproduction. So in theory, everything should be pretty good. Everybody should be pretty happy. Well, that's actually not the case for male reproductive health. Male reproductive health has somewhat lagged behind female reproductive health. And I've just put some examples here to give us some guidance. So, for example, we are still discussing how many men in various regions of the world are actually infertile. We have incredibly limited information on this. Probably about 175 countries in the world, we do not have information on this. We're still discussing, for example, varicocele. And, you know, half believe, half don't believe. You know, what are we supposed to conclude? And this is sort of 60 years later. Other examples, I think, are perhaps equally pertinent. So, for example, we have the semen analysis is a diagnostic cornerstone of male infertility. But apart from that, we have no real diagnostic tests for the men, apart from one or two very small examples. If we think of sperm DNA, for example, we have more reviews on that subject than primary data. And in reality, there is no real new prognostic and diagnostic information from sperm DNA, as an example. And often we tend to rush then for diagnostic and treatment tools, perhaps without doing all the necessary experiments in the first place. So we come along a little bit of a rocky road for that. And there's two studies that I would suggest if you're interested in reading further. One is from the AUA, Peter Schlegel and group, and one is from the WHO. And it's related to the quality of the studies that we have in male reproductive health. So we're lagging behind female reproductive health. And that's where the focus is, I think we should put our attention. So how are we supposed to move forward? You know, do we keep doing the same? Probably going to end us in the same mess that we're in now. Or do we think about how to do things differently? Well, maybe the only positive thing that's come out of the pandemic has shown really clearly to us as a global group that basically when we collaborate together, when we're focused in how to go forward for the future, we can really drive something fantastically well. So, for example, and I'm sure we're all aware of this, in 21st of December 2019 was the report of a pneumonia of unknown cause. Less than 12 months later, we have a vaccine produced, for example, by Pfizer that was 95% effective against COVID-19. That time frame to develop that vaccine is just blows your mind. But it was basically done because everybody collaborated together. Everybody decided this is what we need to do. This is what we need to get organized. And they drove forward collaboratively together. So what I'm suggesting is that actually we could then learn those lessons and say, okay, this is where we are on male reproductive health. How can we go forward? So I wanted to give some examples, familiar examples to us of how we can do this and maybe go forward. So I'm going to go through 4 examples, quite simple for this. Let's deal with the first one, which is related to semen analysis. So as I mentioned, semen analysis is the cornerstone for the investigation of the man. We all know sperm count, sperm motility, sperm morphology. You know, the trio are well known in reproductive medicine. But what is perhaps sort of known, but maybe ignored a little bit, is the fact that actually if we have a diagnosis of a semen analysis is done, say, in Darlington, in Darwin in Australia, or in Dar es Salaam in Africa, the only thing that we can tell is, even if it's the same semen pot, that the result will be different. And what that really means is that technically, for whatever reason, and there are many reasons we could talk about at some stage, we are unable really to do a high quality semen analysis. And this graph here, which is just says it all to me. This is from the UK NEQAS, where you get one affected pot of semen and you just aliquot it out. And then in theory it should all be the same because it's the same pot, so we should all get the same result. Well, that's not the case. Sometimes the man is oligospermic and sometimes the man is a sperm donor, and it's the same sample. And this experiment's been repeated hundreds of times, showing exactly the same result. And it's not just in the UK. You know, we could say in the UK, well, you know, you guys voted for Brexit, clearly you're struggling with things. It's not true. I mean, it's the case in America, it's the case in Australia, it's the case in Germany, and this is an example very recently come from the Netherlands. What it is we can count sperm. We need to be able to count sperm much better. So that's clearly a global problem that we have, that we need to come together and try and understand in more detail how we do training programs virtually or whatever, and then we can get semen analysis done just using one high quality method. And to some degree, I think we're lucky, because the WHO in 2021 and the ISO set standards in semen analysis, and they're much clearer now than they were. And maybe that was a reason for it. I don't think so, but maybe it was part of the reason for it. So what we have here is one standard and one method. So I think that's really, really helpful for us to do that. So I think that's going to be a big plus. What we need to do is globally work on that and work out different training programs that are the same in Argentina versus Hong Kong. And we can then train people to do semen analysis appropriately. But of course, then we have to sort of look to the future. You know, semen analysis is using technology from the 1920s, so it's 100 years old. You know, things have moved on since then. We didn't have the mobile phone 100 years ago, for example. So maybe at some stage we have to think about a technological development for semen analysis. And here's a little an example of how difficult these things can be. Here's a sperm cell going very excited, and then it goes on a linear track, and then it gets excited again, and then it goes on another linear track. And in fact, you know, an analogy I would give is this is like a sperm cell listening to classical music. So it's going here, it's being quiet, and it's not moving very much. And here it's listening to sort of, you know, good old AC/DC, a rock and roll event. So I think it is difficult to do some of these things by eye. So maybe technology will be the future. But we've got to get together and add A and B and get to C, rather than at the moment we can't even add A and B together. So technology may help us, but we've still got to get these virtual training programs. And that's example number one. Let's think of example number two. And this is a graph you've probably seen, maybe not in this format, but you've seen in the standard press many, many, many times. It's a decline in sperm counts. It's what I call the decline in sperm count story. You know, is it real? Of course, this black line looks fantastically dramatic. You know, by the year of 2025 or 2035, you know, we're going to have no sperm. So we're not going to need to worry about global warming because we're just going to have no sperm. Of course, it's not as simple as that. In fact, actually, if you look at some of the other groups, and this is the unselected Western group, if you look at the fertile Western group, for example, there's no change in sperm counts over the last sort of 50 years. So this is a very big debate. It's a very live debate, and it's been a live debate for some time. But what's very interesting is that we still don't really truly know the answer. And one example I'll give you in the next slide is really where we can try and home in on global data to find out what's happening. So this is a paper from Jacques Auger from Paris. And what we have here is this is breaking down this data from Haggy Levine. It's breaking down this just fantastic looking slide that shows a massive decline in sperm counts. And what you see in the United States, Australia, Western Europe, Eastern Europe, Southern Europe, etc., there are huge gaps in the data. So, for example, let's look at Southern Europe. There is zero. There's nothing going on. No studies before 1995. If we look at Australia and New Zealand, there's nothing before the early 90s. If we look at Western Europe, there's big gaps in the data. And what this means is it's very difficult to solve a global problem if we've got huge gaps in the data. What we need to do is come together and plug these gaps. Then we'll be able to tell if there is a clear decline in sperm counts, yes or no. So it won't be a story anymore. It'll be actually fact or fiction. What about number three? Well, number three relates to semen analysis and the reference ranges for semen analysis. So this relates to the new WHO manual, and we have clearly for sperm concentration, sperm motility, and sperm morphology, so-called reference ranges for semen analysis. And this is a detailed analysis of the data. which Martin Campbell produced. And this data is freely available in the University of Dundee website. And we published the fertile ranges in 2021 in a paper in Andrology. But the details of the fifth centile are quite interesting. So what we see is for sperm concentration, it's say 16 million. For sperm motility, it's 42% motility. And for normal forms, it's 4% normal forms. And, you know, there's a lot of data points here. So 3,000 data points. So we could say to ourselves, wow, that's a lot of data. It must be very exciting. So it must be real. It must be fantastic to be able to look at that. But again, when you dig into the data behind this, there are some substantial problems with pulling this data together. So for example, this data is incredibly geographically limited. There is only one study from China. There's only one study from Africa, and that's from Egypt. And the implication that is the reference ranges just come from Egypt are applicable to all of Africa. And clearly that's not true. So although we've got 3,000 people in this reference ranges, we need many more from a much more geographical spread. And we need prospective studies, not retrospective studies. A simple example, there's no data from South America. I mean, the whole of the continent, and there's no data. So these are massive gaps in data that we can fill if we're thinking in a global way and we're thinking to the future. And the last example I'll give is that, you know, I've been involved in reproductive medicine or male reproductive health, whatever you want to, it's the best terminology, for sort of 25, 30 years. And the male pill has been on the horizon every year for the last 25 years. And we still don't have it. We're still waiting. So it's like waiting for a bus. I mean, there's nothing happening. No buses are coming. And this is incredibly frustrating because clearly the contraceptive choices that are available for couples are very limited. And there are severe difficulties with a number of these choices. There needs to be much more choice, just generally. But a big gap relates to the male. So we have condoms and we have vasectomy, and there are big problems with both of those, of course. But we don't have the male pill. It still isn't here. There's been many attempts to doing this, but at the moment it's not there. Now, here I can see some really, truly amazing progress that's going to occur. And the example I would give is the Bill and Melinda Gates Foundation, where they've realized that contraception is a huge global issue, and that is a very widespread challenge, not just to reproductive medicine, but of course to the world. And they've committed to spending about $280 million per year from 2021 to 2030 to develop new and improved contraceptive technologies. And I'd suggest just have a look at this website from the Bill and Melinda Gates Foundation. They have taken the bull by the horns and they've said, right, this is a big issue. We need to globally look at this. We need to get some experts together. We need to start funding this area, and we need to make some progress in the next 10 years. And that is exactly the way that these things should be done. But of course, it needs vision, it needs money, and it needs drivers from the top as well as, of course, from the bottom. So what are these networks? Well, up until a few years ago, basically, there were none. No surprise. And that's why progress has been pretty poor. But that's not the case now. So there is a one group, for example, the ESHRE Male Reproductive Health Initiative, which I'm fortunate to be part of with 13 other people. And we're just having a meeting in Budapest in a couple of weeks to look at the future for male reproductive health. So we've set up a pathway, strategic pathway, which we need to go down for looking at the future for male reproductive health. And this includes people like Sartu from Fertility Europe, includes scientists, includes clinicians, includes people from South America, etc., etc. But that's not the only one. There are, for example, the EU COST, which is run by Rafael from Barcelona, is a training program and also a research program related just to Europe. There's an amazing example in Australia where they've got the healthy male. So they have funding from the government, Moira O'Brien and Rob McLaughlin, for example, which is several $1 million to really get at what are the causes of male infertility and how do you pass this to the public? How do you give public information related to this? It's a very complicated thing to actually do. There are genetic consortium in male reproductive health. And this is very important because, you know, what we have here is that 20 years ago, genetics used to be just get a few patients together and do some sequencing. Those days are completely gone. You cannot do that anymore. You've got to get large numbers and high powerful collaborations. And it's fantastic what Joris and colleagues have done for the International Consortium on Male Genetics. There's also another one very recently from Ashok Agarwal, looking at Global Andrology Forum, which is looking at pulling people together from different regions. So I think there are some very recently, the last couple of years, but there are some really good initiatives where hopefully what we've talked about, the challenges that we've had, these initiatives can help us really go forward and try and attack some of the problems that I've talked about. So if I could summarize, ladies and gentlemen, what hopefully I've put to you is that male reproductive health is an amazing subject to be involved in. Of course, that's one of the reasons why you're involved in it. But it's male reproductive health has not perhaps gained the same traction as female reproductive health. And there's a bit of an illusion of progress. It looks like we made progress, we've got ICSI, etc., etc. But you know, we haven't really known. For example, there's no pill a man can take, not just for contraception, but to improve his sperm count. You know, there doesn't exist. And, you know, that's a crazy situation, to be brutally honest. So the way forward to do this is to have global collaboration because it's essential. And the example I've given is related to the COVID pandemic, how we've really managed to transform things in COVID-19. So I think if we follow rigorous rules, global collaboration, high quality science, collaboration between clinicians, scientists, counsellors, politicians, policymakers, etc. from around the world, we can really make some traction. And I've tried to also show individual examples of networks that are actually trying to do that. So hopefully you'll get involved in some of these networks, and hopefully in the next 5 years we'll see some real fantastic progress. Thank you very much for listening.
Thank you very much, Chris. Excellent presentation, as I knew you would deliver. And whilst I like the concept of the male pill, I would be extremely anxious about compliance, but we'll wait and see what happens there. So to continue the theme of male infertility and investigations, I'd now like to introduce Professor Sandro Esteves, founder and medical director of Androfert, the Andrology and Human Reproduction Clinic in Brazil. And Sandro is also a co-founder of the Poseidon Group that developed the novel classification system anticipated to improve counselling and management of low prognosis patients and a reduction in time to live birth. Sandro also serves as chair of the male infertility section of the WHO Infertility Guidelines Development Group and will present the value of basic and extended semen examinations for decision making. Thank you, Sandro.
Hello, everyone. Thank you for taking time out and being here today. I'm Sandro Esteves, and I'm delighted to participate in this virtual workshop for fertility nurses and midwives organized by Medea. Today, I will share with you essential knowledge on semen analysis. This slide includes my disclosures. I have no potential conflict of interest related to the contents of my presentation. Here is an outline of what I'll be covering today. I will discuss the importance of the semen analysis and how it should be performed according to the WHO manual. I will also provide you with an overview of advanced semen tests and what the WHO manual recommends. And lastly, I will explain how the results of semen analysis can help decision-making in the IVF unit. So let's get started. Since the 80s, the WHO manuals have provided us guidance on how to perform semen analysis. These manuals are revised periodically, incorporating new evidence and refining concepts that need more explanation. Each manual includes protocols and reference standards. And although these manuals are not kind of used for all clinics across the globe, they have been quite significantly used by IVF units, andrology laboratories, and this is the manuals that we use in our clinics for assessing the semen analysis, and I believe they are used in yours as well. In this recent article that I invite you to read, I critically assessed the evolution of the WHO manuals, focusing on the last 2 editions, and also the value of semen analysis in the management of couple infertility. I will discuss the most important aspects of this publication in the following slides. So the 5th edition of the WHO manual, published in 2010, is currently the manual used worldwide by most clinical and research andrology laboratories, as well as fertility centers. This manual has a section dedicated to basic semen analysis, and also a section dedicated to advanced testing, optional testings, for example, biochemical assays and computer-assisted semen analysis, and also a section dedicated to research semen tests like oxidative stress and sperm DNA damage. It has also sections dedicated to sperm preparation techniques and sperm cryopreservation, and a section about quality control and quality assurance. But perhaps the most remarkable change between the 2010 manual and its predecessors was the incorporation of clinical chemistry foundations to generate reference ranges for semen volume and basic semen parameters. Using data of recent fathers, the distribution's 50th percentile values of semen volume, sperm concentration, total sperm count, total motility, progressive motility, morphology, evaluated by the strict criteria, and vitality were chosen as the lower reference limits. This is what you see when you have reports on semen analysis. These reference ranges are presented for evaluating the patient profile and then comparing to the reference ranges. These 2010 reference limits were substantially different from those of former manuals, raising much debate. That reference limits in the manuals before 2010 relied on the clinical experience of researchers evaluating sperm parameters in fertile men with not specified time to pregnancy. This is not ideal because over or under referral for male infertility investigation or also IVF ICSI treatment can happen when decisions are made based on imprecisely defined reference populations. But I feel it's essential for you to understand how the 2010 values were generated. So our reference range was obtained from a relatively well-defined population of recent fathers for the first time. Recent fathers were defined as men from couples who had achieved a natural pregnancy within 1 year from stopping contraception. Patients who were attending an infertility clinic or undergoing fertility assessment were excluded. So the semen analysis of the so-called recent fathers were carried out in laboratories applying rigorous analytical methods and enrolled in quality control programs. On this basis, it was assumed that this population best represented fertile men. However, criticisms were raised because data from only about 2,000 men from restricted geographic regions were used for generating the reference ranges. Despite that, the 2010 reference limits have been used extensively since the manual release for decision-making. Now, after 10 years since the last manual, the much anticipated 6th edition was released in 2021 with important updates. Several chapters were revised and new chapters were added, particularly concerning advanced sperm function tests. Protocols to perform tests that became obsolete were discontinued, like the sperm penetration assays. The new chapters mainly included information about the potential clinical utility of sperm function testing, like sperm DNA fragmentation and oxidative stress, The manual provides step-by-step protocols on how these tests should be performed. And unlike previous editions labeling advanced sperm function assessment as research tests, the new manual acknowledges that sperm DNA fragmentation and sperm aneuploidy tests, for example, may be clinically informative in certain situations by the laboratory choice or clinician's particular request. The sperm processing and cryopreservation chapters were improved as well, with more detailed protocols, and the section related to quality control and quality assurance was revised to facilitate understanding by non-statisticians. An essential feature of the 2021 manual was the incorporation of new semen analysis data from recent fathers, updating the reference distribution of semen parameters that had been published in the previous edition. In this 2021 edition, semen analysis data from 5 countries published since the release of the 2010 manual, and including about 1,800 recent fathers from Italy, Greece, Iran, Egypt, and China were added. These data were pooled with those used to generate the 2010 reference ranges. Collectively, the reference interval provided in the 2021 manual originates from a population nearly twice higher than the 2010 edition. Based on the new pooled data, the 50th percentile values for sperm volume, concentration, motility, and morphology distributions differed slightly from those of the 2010 edition. But the similarities between the two manuals are good news. They indicate that the inclusion of more diverse populations did not change the reference ranges significantly, suggesting more generalizability. Still, densely populated geographic regions remain underrepresented, and we don't know if values will change when data from these regions are incorporated. What is essential to understand is that you need to exercise caution when using the WHO semen analysis reference values for decision-making. Always remember that these values only represent the distribution of semen parameters of a limited group of recent fathers from quite a few countries. We still don't know whether regional reference values would be more clinically relevant than values obtained by pooling the data from different populations. I will give you a brief overview now on how a semen analysis should be performed according to the WHO 2021 guidelines. Basic semen analysis has 4 critical pillars. First, pre-analytical aspects, including patient instructions on how to provide the specimen, ejaculatory abstinence that should be always between 2 to 7 days, and recording of any medication that could affect the results. Second, the microscopic examination of seminal fluid, mainly including pH and semen volume. This needs to be carried out by weighting the specimen because the volume assessment by pipetting underestimates the amount of fluid. Third, microscopic examination, which includes assessment of sperm concentration, total sperm count, motility, vitality, and morphology. For count and motility, replicate assessments are recommended. Each replicate is a separate fresh-wet preparation. And as sperm motility decreases with time after ejaculation, the examination should start within 30 minutes of ejaculation when liquefaction is complete. A standard temperature of 37 degrees for sperm motility assessment is also required. Morphology should be evaluated by the strict criteria, and vitality assessment is only necessary when total motility is less than 40%. Lastly, post-analytical aspects relating to calculations, reporting of results, quality control, and quality assurance is also kind of important for the semen analysis performed according to the WHO manual. Here you can see the main new recommendations and updated information provided by the 2021 manual concerning the basic semen analysis. Perhaps the most significant change regards sperm motility categorization, which was reverted to that of the 1999 WHO manual, in which sperm are classified as fast progressive, grade A, slow progressive, grade B, non-progressively motile, grade C, and immoral, grade D. In the new manual, a section named Extended Examination was included, grouping the tests that may be used clinically in certain situations by choice of the laboratory or particular request from the clinician. Some tests, like sperm DNA fragmentation, were upgraded because they were considered only research tools in the previous edition. Others, like, for example, assessment of leukocytes in semen, were downgraded, as in the previous manual, leukocyte assessment were part of the basic semen examination. Extended examinations include many tests, but today I want to talk about sperm DNA fragmentation because I consider that these tests highly informative in investigating the competence of the human sperm to fertilize the egg and promote healthy embryo development. The new manual includes protocols for the main sperm DNA fragmentation tests, the tunnel assay, sperm chromatin dispersion test, also known as the halo test, the COMET assay, and the sperm chromatin structure assay. We recently reviewed the evidence and elaborated a clinical practice guideline concerning the situations where sperm DNA fragmentation testing may be indicated. The guideline development group included reproductive urologists like myself, scientists involved in the development of the tests, and reproductive endocrinologists. If you are interested to learn more about sperm DNA fragmentation, I invite you to check this open access paper published in journal named Andrologia. In brief, for a reliable assessment of sperm DNA fragmentation, it is critical to use a validated test. The examination must be carried out in neat semen collected after ejaculatory abstinence of 2 to 5 days, but preferentially 2 to 3 days. Concerning ejaculation interval, it is critical to use a fixed ejaculatory abstinence length when the test is used to monitor the effects of any intervention to reduce sperm DNA fragmentation levels. If correctly performed, the 4 sperm DNA fragmentation tests provide valid information concerning the risk of male infertility and the probability of reproductive success, both for natural and assisted conception. Examples of situations in which these tests can be clinically informative for explanatory purpose or clinical decision-making, including varicocele, particularly in cases of palpable varicocele and borderline or normal basic semen analysis, in which there is doubt whether or not the varicocele should be fixed according to the recommendations of the most relevant urological guidelines. Second, in cases of unexplained couple infertility or idiopathic male infertility. Third, in cases of recurrent pregnancy loss. Fourth, before intrauterine insemination. Fifth, before IVF-ICSI, particularly when a paternal factor is suspected. Sixth, for fertility counseling, mainly when risk factors for oxidative stress exist, and before sperm banking. In these conditions, sperm DNA fragmentation testing can provide helpful information about the contribution of sperm chromatin to infertility and possibly guide the treatment plan. Sperm DNA fragmentation tests have also been included in other relevant clinical guidelines. For instance, the 2017 ASHRI Recurrent Pregnancy Loss Guidelines provide a conditional recommendation for sperm DNA fragmentation testing during the investigation, based on a moderate association between pathological sperm DNA fragmentation levels and recurrent pregnancy loss. Indeed, current evidence indicates that sperm DNA fragmentation levels are markedly higher in the partners of women suffering from recurrent pregnancy loss than in controls. And more recently, the European Association of Urology Male Infertility Guidelines provided a strong recommendation for assessing sperm DNA fragmentation in couples with recurrent pregnancy loss from natural conception or failed ART, and for men with unexplained infertility. Also, last year, the joint ASRM-AUA male infertility guidelines included a recommendation for sperm DNA fragmentation testing in men from couples having recurrent pregnancy loss. The main advantage of performing sperm DNA fragmentation testing in these scenarios is that it allows initiating an andrological assessment for men who would not otherwise be routinely viewed by specialists. The andrological investigation provides the opportunity to identify and correct reversible causes associated with sperm DNA fragmentation, potentially increasing the chances of natural conception or potentially improving ART outcomes. We recently summarized the rationale and effects of the primary interventions in this review article published in Andrology, which I also invite you to check. It includes information on lifestyle modifications, antioxidant therapy, treatment of underlying conditions like a varicocele, genital infections and chronic diseases, hormonal therapy, and also the use of testicular sperm in preference over ejaculated sperm for ICSI. Now I want to move to my last point, semen analysis results and decision-making in the ART unit, where I believe most of you work. The semen analysis is the most critical laboratory test to evaluate men's fertility aptitude. It provides information about spermatogenesis and accessory glands function that might help in diagnosis, counseling, and follow-up of male infertility treatment. The results of semen analysis also help in choosing sperm selection techniques for IUI, IVF, and ICSI, selecting the most optimal assisted conception modality, and certain decisions in the ART units, like the need for precautionary cryopreservation. But what is essential to understand is that semen analysis is a complex laboratory procedure that needs to be performed in an andrology laboratory equipped with well-trained technicians, internal and external quality control, validated systems and processes, and quality assurance. Reliability and accuracy are essential because semen analysis is frequently the gateway test on which basis costly and invasive treatments are prescribed. Clinicians should consider these aspects when choosing a laboratory to perform their patient's semen analysis. Concerning the usefulness of semen analysis results for the choice of sperm selection techniques, we need to acknowledge that there is no consensus. What is essential to know is that traditional sperm selection techniques are not ideal for selecting sperm fractions with optimal DNA integrity and functional characteristics. Swim up, for example, is limited to semen with high sperm count and good motility. The density gradient centrifugation, by contrast, allows recovery of higher sperm yield and is more suitable for oligozoospermic and poor sperm quality specimens. But centrifugation can increase sperm DNA fragmentation induced by reactive oxygen species. Advanced sperm selection techniques have now been introduced for potentially optimizing functional sperm recovery for use in IUI and IVF ICSI. However, the best quality research does not show any essential differences in live birth rates when these techniques are compared with the density gradient centrifugation or swim-up. Currently, there is insufficient data to support the use of advanced sperm selection techniques routinely for sperm preparation. They're using specific groups of patients, such as those with elevated sperm DNA fragmentation, remains to be explored. In our clinic, we use different techniques according to the patient profile. In your clinic, you need to choose the best sperm selection technique that best suits your needs based on your own semen analysis experience, available resources, and also costs. Here's a snapshot of what we use in our clinic. We routinely combine the results of the basic semen analysis and sperm DNA fragmentation testing for decision-making. Density gradient centrifugation, swim up, or microfluidics devices are typically used for selecting sperm for ART, mainly based on sperm concentration, total sperm count, and motility in our clinic. Sperm DNA fragmentation test results are also used for decision making, and in selected cases of elevated sperm DNA fragmentation, our approach is to use testicular sperm for ICSI. The semen analysis results may also help in choosing the most suitable assisted conception treatment. Like the previous topic, there is highly variability among clinics in this area. And in this particular case, decisions should be based on combining semen analysis results with the couple's clinical characteristics. In general terms, IUI is considered for eligible couples when semen analysis show normal zoospermia or mild oligoasthenozoospermia. And some groups like ours also use sperm DNA fragmentation testing results for eligibility criteria. Conventional IVF is generally considered for couples with unexplained infertility, pure female infertility factors, or mild semen abnormalities. The indications for ICSI primarily include severe male infertility, but its use in non-male factor indications has increased steadily in recent years. Nowadays, ICSI as a method of fertilization represents about 70% of all ART cases performed worldwide with some regional variations. The semen analysis results are also potentially beneficial to deciding on the need to cryobank sperm as a precautionary measure. This strategy can be of particular value for patients with sperm counts at the extreme lower limits, including patients with semen analysis showing fluctuations between azoospermia, severe oligozoospermia, and cryptozoospermia. These patients are usually under a lot of stress during the ART treatment and may have difficulties providing a specimen suitable for ICSI on the day of oocyte pickup. Patients with difficulties in providing a specimen for semen analysis may also benefit from cryobanking. It may avoid unpleasant situations on the day of oocyte pickup. And for low sperm quantities, our approach has been to use sperm vitrification, like the cell sleeper method illustrated in this slide. Lastly, severe morphological defects on a semen analysis, such as the lack of acrosome, short tails, or mid-piece abnormalities, could prompt the lab to apply oocyte activation after ICSI. This strategy has been shown to improve pregnancy rates potentially in couples whose male partners have these abnormalities detected on a semen analysis. But although the results of semen analysis might be helpful for better decision-making in the ART unit, what is essential to discuss is that, unfortunately, the male partner is often overlooked in the evaluation and treatment of infertility. A semen analysis is frequently the only test to assess a man's fertility potential. However, as reasoned in this comment I have written for The Lancet, a male infertility workup primarily based on a basic semen analysis does not provide men with an optimal fertility pathway for three main reasons. First, basic semen parameters do not reliably discriminate fertile from subfertile men. In fact, there's a substantial overlap between semen analysis results of these individuals, and in about 30% of men facing infertility, the routine semen parameters are within the reference ranges. Second, the results of a basic semen analysis have a low predictive value for natural fertilization and also ART success, unless the sperm parameters are at the lowest limits. And third, semen analysis, as routinely performed, does not include functional tests and therefore is unable to detect sperm DNA and epigenetic alterations that might affect embryo development and implantation and also offspring health. Additionally, female factors also adversely affect a couple's fertility potential. This is why a simultaneous assessment of both partners is required to determine the fertility potential of every couple, and the most recent clinical guidelines have stressed this essential knowledge. A well-conducted male infertility workup must include a detailed medical and reproductive history of the patient, physical examination, and at least 2 basic semen analysis as a first-line investigation. Second-line investigation, such as hormonal assessment, sperm functional tests, genetic analysis, and imaging studies might be necessary based on the clinical and semen analysis finding. I firmly believe that all men from a subfertile couple should be assessed by well-trained urologists or andrologists who have expertise in male reproduction, which is the routine practice in our clinics. A comprehensive male infertility evaluation has several advantages. It can help identify potentially correctable conditions, such as varicocele, genital tract infections, obstruction, endocrine disorders, inadequate lifestyle, and exposure to toxicants, just to cite a few. Second, it can identify conditions that cannot be treated, but are suitable for IVF ICSI using the patient's own sperm. Third, it can also help in recognizing situations where donor insemination or adoption are the only alternatives. A complete male infertility evaluation might also identify health-threatening conditions or related coexistent diseases that require medical care. And lastly, it could reveal conditions that might affect patient or offspring health, mainly in patients using ART. We can cite, for example, advanced paternal age, inadequate lifestyle, use of potentially gonadotropic or teratogenic medication, and also genetic defects. And based on this evaluation, the affected couples can be counseled accordingly. That brings us to the end. In conclusion, global standardization is needed for development in andrology, and the WHO Semen Analysis Manual is a valuable instrument to move clinical practice and research in male reproductive health and andrology. Traditional semen analysis remains a very important component of male infertility evaluation, but still, an advanced sperm function assessment is needed to identify specific sperm defects, adding knowledge for fertility counseling, diagnosis, and treatment planning. However, medical and infertility conditions underlying an abnormal semen analysis or an abnormal sperm functional test will only be reviewed and potentially treated or alleviated through a complete male infertility workup. The good news is that male infertility has been increasingly recognized as a disease and a public health concern. Its prevention and management should be an integral part of an inclusive sexual and reproductive health agenda. But to ensure a bright future for male reproductive health and andrology, we need more investment in research, technical innovation, education, and training. I'm providing you with a list of key references, but feel free to contact me by email if you need further information. Thank you very much for being with me today.